Alena Berube. Alena Berube is the Director of Policy for the Green Mountain Care Board. This is Vermont's independent regulatory body that oversees health system performance. She's also a PhD student at the Dartmouth Institute for Health Policy and Clinical Practice, where her research is focused on the drivers and impacts of high-performing health systems. She brings an extensive experience in large-scale policy development and implementation of new programs. Before entering the field of health policy, she worked in other public domains, including education, finance, and tax policy, building a foundation in public finance and evidence-based policymaking. She also has a background in organizational science research and previously worked in the private sector in corporate finance and business process improvement. The focus on enhancing efficiency and strategic decision-making within complex organizations. She holds a Master of Science degree in Strategic Management and Entrepreneurship from the University of Maryland, College Park, and a Bachelor's in Finance from Virginia Tech. So, Alena, welcome to this internship program.
Thank you. Yeah, so I'm hoping this will be an informal conversation, and we can like dig in anywhere you'd like. I think Marvin, you sent me a list of 4 questions that I've kind of been thinking about, so we can kind of go one by one, and then if it's helpful, I didn't create slides for this purpose, but we did a presentation, or I did a presentation to the legislature earlier this year that addressed kind of some of these kind of more fundamental questions about healthcare as a market and kind of why we might want to think about regulating healthcare and how. And when I say healthcare, I mean kind of the financial aspect of healthcare payment and delivery system reform. So would it me to go question by question? How do you want to?
Yeah, I think so. So as is the case, having been raised Jewish, we have a holiday called Passover, which has the 4 questions. So I sent 4 questions, so they are different from the ones on Passover. And we'll start out with one sort of based in what Vermont has been doing. In 2011, we signed a law into existence called the Green Mountain Care Act, or something close to that. And it was going to create a universal healthcare system. And we'll talk about that a little later. That system was never implemented. It was supposed to be called Green Mountain Care. But the other part of it was it created a board called the Green Mountain Care Board. And it looks to me like its main activities and its main power are targeted toward cost control, and they're to regulate hospital budgets and insurance company rates. In other words, limiting rate increases. So the question I have for Alena is, that's been our strategy here for 12 years. Does a state government regulating hospital budgets and insurance company rates, is that an effective cost control strategy? And compare it to the laissez-faire approach in many other states where the government does not do either of those things. But I'd love to hear, Alena, what your thoughts are and whether they represent the consensus of the Green Mountain Care Board.
Great, yeah, and I might answer this 2 ways. One as a kind of Green Mountain Care Board staff, and another as someone who's been working in this area in research and working with other states and collaborators. So, you know, I'd like to start with first, like why we might regulate this industry to begin with. So is it okay if I share these slides? I think we'll just start here and then I'll kind of get back to your question.
Of course.
So this is the presentation I referenced that I presented to the committee of the Senate Health and Welfare Committee in Vermont. So, you know, we talked about kind of the funding mechanisms. We have a very complicated, you know, multi-payer system, and there's many ways that healthcare gets paid for, you know, in this country. And I think you may have already kind of experienced that or be aware of that. You know, we talked about, you know, why doesn't the healthcare market work? This is kind of one reason why you might have regulation. The healthcare market has poor information, so patients have less medical knowledge than providers, and often don't understand the value of services or prices for services in advance of obtaining those services. So, you know, it's not that we have some emergency experience when patients are in need of care right now. There really isn't a market for emergency care. You kind of just go where you need to go to get the care that you need, right? And you don't think about, the cost of that care before you go. Healthcare markets also can reflect conflicts of interest between patients and providers. Not necessarily physicians or clinicians, but perhaps the organizations they work for may not share the same interests. So, I think where patients kind of want to minimize the revenue, the cost of care, and what they're paying for care when they need it over time and in the moment, organizations and, particularly for-profit organizations and even nonprofit organizations often have incentives to maximize the revenue that they're bringing in. Some of that is good. It's to serve other patients, to serve the mission, to cover the costs. We need to make sure our organizations are sustainable. But there are some kind of conflicting interests in terms of kind of how that happens and how much that happens, as we can imagine. And you may get to with the corporate medicine discussions later on. Healthcare markets also entail kind of emotional decisions. So people are not rational actors. Healthcare decisions are emotional, and this can lead to individual decisions to overspend on healthcare that yield only marginal returns. I will tell you just from my own personal experience going to the dermatologist. She was a great dermatologist. I won't name names. I won't even name the organization, but I think she let in once with, well, to give you peace of mind, we could do this. And that for me, I was like, whoa, to give me peace of mind. But then I was like, oh, but really, I do need to think about my children. Maybe I do need to spend $3,000 to have, this biopsy taken. So, even for people who may want to make rational decisions and who have all the knowledge that they think they can enter this and make good, cost-effective decisions, it is an incredibly emotional situation when engaging and kind of thinking about the care you need. And then, healthcare markets don't seem to work, when there's a lack of competition. I think this is particularly the case in Vermont and more rural areas where you have kind of a wide, geographic distribution of services. It may not be feasible to shop for services or to even get the time it takes to travel for services. There are high startup costs for facilities. So it's not like if one hospital isn't doing its job, we're going to go build another one. We don't really typically see new infrastructure being built on that scale. And so it's really important to kind of think about kind of these dynamics when we're thinking about regulation. So I won't go through the whole slide deck, but I thought that was an important kind of context. And I have to figure out how to unshare. Stop sharing. Okay, I can't figure out how to unshare, but if I close it, will it go away? Okay, great. So, to get back to your question on Vermont specifically, I think for these reasons, there many decades ago, there was more regulation across the nation at states, at least in terms of price regulation. And that has kind of ebbed and flowed over the years. I think what you've seen in Green Mountain Care Board, as Martin described, had been given all of these authorities to hopefully implement a single payer program that did not pan out. We did kind of continue maintaining, and though we did not exercise all those authorities, we have the authority to set prices, to do kind of planning initiatives, and for a variety of other kind of single payer related operations. What we have seen, and I'll talk about what we've seen in Vermont, but I'll continue on the national scale, is there has been an uptick in regulation or discussions about regulating hospital prices in particular across other states. So a lot of other states have kind of recognized high costs and unaffordability of care, and are starting to think about price caps and different ways that we can kind of move towards a more affordable system. I think in Vermont, has this worked as a cost-effective strategy? We also had something else going on at the same time over the last decade called the all-payer model. So while we didn't have single payer, there was a shift to think about how do we shift care more upstream and what kind of incentive structures could we offer, or different ways of paying for care that might allow the delivery system to reprioritize how it's delivering care and think more creatively across the continuum to serve patients better. That I think it's important to also think about implementation. So there are a lot of great ideas in this experiment, but it didn't really pan out, I think, the way many had anticipated it. We had a hospital-led ACO. It required a coalition of the willing. It was, I don't think we made the full switch from fee-for-service to, a way of paying for care that allowed physicians or clinicians to actually think about doing things differently. And so I think it kind of fell apart. But that I wanted to add that because I think it's not just hospital budgets and rate review, but we had this other big reform initiative that was really, that we invested a lot in to kind of change the way that we deliver care. If we think about hospital budgets specifically, I'll take those for a moment. I think it's not only a cost containment tool, but also a way to ensure kind of equitable access to care across our communities. So I think part of why we had this process was to make sure that we didn't end up with kind of the two big hospitals on either side of our state in Vermont, Dartmouth and UVM, from kind of gobbling up all the little guys, if you will, due to kind of financial challenges. And so I think the hospital budget process was a way to say, okay, here's the allowable growth that we will give you in this community to make sure that you can deliver care. In terms of rate review, which I'll get to a little bit later in some of your other questions, this is the board oversees part of the insurance market. We have another agency in the state of Vermont that's responsible for setting standards around insurer solvency, which is really important for to ensure that insurers can pay for the care that patients utilize, and that we can spread that risk appropriately. So the board's role in this is to review a portion of the market, as I mentioned, and kind of set thresholds for allowable growth rates for rates that is kind of given the solvency needs of the organization. And so that in that context, what we're seeing is kind of a huge explosion of rates and a huge affordability crisis that, and you may have read in the news, I think it's even made national news, like Vermont has some of the highest insurance rates and insurance rate growth in recent years of all states across the country. So that is particularly concerning. So I would say from that perspective, we have been kind of looking at our regulatory levers and reevaluating kind of how we regulate. This year, the legislature passed a variety of bills. One was to cap pharmacy or hospital administered drug prices. I think some of our hospitals were upwards of 6,000% of Medicare, which means that there's also a patient cost component, and patients are paying out-of-pocket prices. A lot of that revenue was used to subsidize other services. It went to reserves. It went to administrative bonuses for executive staff. So there's a lot of ways that money is flowing through the system that we're trying to understand. And so I think there's a lot going on here, and I think there's a lot of opportunity to do things better. But I think that if we think about the laissez-faire approach, there are a lot of risks to not doing work. There's also risks to doing work. So I think thinking about, you may come across in your studies the theories of implementation science, and really thinking about what the policies are, what you're trying to achieve with those policies, what you're measuring, and kind of monitoring and kind of continuing to improve are really important as we move forward. I don't think anyone has figured out what the right level is. So, we think about regulation, it can happen in aggregate, it can happen at a very micro level. And so part of, this regulation versus laissez-faire is really a question of how do you regulate, and kind of what goals are you trying to achieve with that regulation? So that's kind of what I would say on that, but I'm happy to answer questions.
Alena, I'm sorry, I just want to focus more. I just want to have a more tighter focus.
Yeah.
It's absolutely correct that there was this big experiment with value-based care, and we've already had discussions about value-based care.
Oh, great.
And nationally, it had largely it's had largely the same results as in Vermont, which is no useful effect, increased administrative costs. It all sounded good in theory, but just not happening. And it's also an extremely complicated discussion, and we had a speaker on it yesterday. So I guess I'd like to really know. It looks these other two strategies, regulating hospital budgets and regulating insurance rates. It looks to me like those should have succeeded. Like
Right.
you could just say to the biggest hospital in the state, which is half of the state's healthcare budget, you just said to them, no, we don't want any rate increase, or we're going to limit you to 2% or some number. But at the end of the day, as you said, we've ended up with the highest the highest rate of health inflation, at least for the commercial insurance market, which is an important one. So I guess there seem to be factors in the inflation that your strategy couldn't contend with. They said that they couldn't provide the care at the rate you were offering them. So why didn't that work?
Yeah, I think that's a great question. I mean, I think why didn't it work? I think you have to think about the system as a whole. And so you can't have, we have a small state. We have 600,000 people in our state. That is, often smaller than some, small metro areas in other states that are served by one hospital, right? And we have 14 hospitals, one of which is an academic medical center. So we have a lot of infrastructure. We have an academic medical center that has grown, I believe, upwards of 60% over the last couple of years. What the budget process doesn't do is tell hospitals how to provide care and which services to provide. So you're often in this discussion around, okay, well, I need this rate in order to provide more access to care. And so that becomes a really hard thing to talk about, right? And so part of that, the board's work, and I don't think we have not had a process. We don't have central planning in Vermont. But what came out of the legislative session this past year was, okay, well, maybe we should have a state plan to help our system prioritize which services we should be protecting and ensuring continue and aren't shed at the expense of other kind of less essential services. We want to make sure that we've at least got our bases covered before we start kind of adding on. Whereas we've kind of seen the opposite. We've seen hospitals kind of prioritizing those services that generate revenue, but not those services that we really need to make sure are maintained across our communities for the safety and population health, right? And so I think, to your point, has it worked? I think it needs to be, we're at a place where it needs to be reformed. And I think there's a recognition that we need to kind of look at how we're regulating and have deeper conversations around the pricing and the services that are being shed and versus those that are being preserved. Does that get to your question?
I'm not sure. I don't. We couldn't. You're saying we couldn't control their budgets, and they couldn't provide the care at the lower rate increases that we were trying to impose on them. And so is the idea that they genuinely couldn't provide the care for some reason, or did you start investigating how they were spending their money, and they turned, especially this university hospital, turned out to be wasteful? Is that more the idea?
I think that's exactly the point. So, the budget process has happened kind of at the aggregate level. So we've been tying it to economic growth, which is approximately 3.5%. But regulation has been happening at this aggregate level. It has not gone down to the level of saying, hospital, we want to see X, Y, and Z in, this budget is for this set of services, or this budget expects this level of administrative expense. We have not gone to that level. And so I think those are the conversations now. We've been asking why do you need this rate increase? Why do you need 25% in a 1-year time span, which was what was happening just post-COVID. And it became very apparent that a lot of the rate increases demanded could have easily been absorbed. And so I think there is this tension now with trying to do the investigative work and understand kind of where those opportunities are. So we do know that the UVM Health Network does have a very high level of administrative costs compared to even their peers, academic medical centers. And so that is an area that we are, working with them to understand like how many costs can actually come out while preserving access to essential services.
Yeah. Okay, so Vermont's healthcare system, grossly speaking, is led by the University Hospital. We spend a lot on Dartmouth across the river, New Hampshire. And then we have rural hospitals. Most of the rest of the hospitals are small rural hospitals. Over half of them are threatened. So I'm going to let Natalia go, but I just want to give that context. On the one hand, we have a university hospital, small tertiary care hospital, but that's where the university is, that seems to be overspending. And then we have struggling rural hospitals. And now I heard you say that you're just now thinking about expanding your power to develop a healthcare plan for the whole state, rather than just saying we're going to deal with hospital budgets and insurance rate regulation.
No,
so that'd be much more ambitious.
No, we're not expanding our power. So I apologize if that was miscommunicated. So the legislature has asked the Agency of Human Services to establish a state plan and for the board to review hospitals' budgets in conjunction with that state plan. So it's not an expanded authority.
So you couldn't close a wasteful hospital if you wanted to, that looked to be unnecessary?
No, I don't think the board is in the business of closing hospitals, no.
Natalia, go ahead.
I think Zachary had his hand up before me, so if Zachary, you want to go.
It's okay. You got it, Natalia.
Okay. I mean, part of this might just be I need some clarification, but also I'm just curious if like, you're saying there's been a ceiling on how much a hospital can grow itself, and they're still just kind of like making their money however they like, but they can't grow beyond a certain point. And then, so I'm curious, like, if you guys have thought about global budgets and kind of how this differs from global budgets for hospitals.
That's an excellent question. So in our current system, the current budget process, we establish a cap on how much they can grow. They often grow beyond that anyway, which means that they have to come back to the board, and usually they're supposed to ask for a budget adjustment. What happens is they don't, and they bake that cost and bring it forward. And so we're kind of playing this catch-up game where we're trying to reduce prices in response to overspending. Because if they, for example, what hospitals, a trend that has occurred is that they will underestimate the volume. They will get a price that is higher than the volume that perhaps they need. And I'm not saying this is the case for all hospitals. I think small rural hospitals have a different kind of dynamic, but kind of your larger PPS hospitals who do receive more of the volume. And then what you have at the end of the day is an overage relative to that estimated budget cap. And so part of the challenge of this model is that we're not regulating the reimbursement. We're regulating the budget. And so I think a global budget, I mean, there's multiple ways to think about a global budget. Is it a global payment where I'm saying I'm going to give you a lump sum to take care for this population in advance? And there's many ways, like, is that, typically that happens at the insurer level. It can also happen at a facility level. So I think Maryland has a model where they give hospitals lump sum payment. And then you don't see those kinds of overages. What you see in Maryland is actually another dynamic where some of that care is bleeding outside of the hospital, and you see entities popping up. And so controlling the total cost of care is still a challenge because you have other entities kind of filling those gaps that are unregulated. I don't think we would quite have the same kind of dynamics in Vermont if we were to move to a global payment system. But the way that our hospital budget system works right now is very analogous to a global budget, kind of in the budgetary sense of things. But that was a great question. Eddie.
Natalia, did that answer your question?
Yeah, that was helpful.
Betty, are you on mute? Did you want to ask a question, or Zach?
Zach wanted to go next. Go ahead.
I'm okay.
So I'm still confused about how Maryland works. I thought that the idea was that in Maryland, they set their prices to make the budgets work right. And then in the middle of the year, they change the prices if the hospitals are making too much money, hospital by hospital. So they're not, so the way I picture it, a global hospital budget is where there's a budget for the whole year. And then wherever the money is coming from goes to each one, whether it's monthly or quarterly, that fraction gets paid out. And you don't have other revenue. So you have to live within that. So that's how I picture a global hospital budget. And Maryland doesn't do that. Vermont doesn't do that because we don't give them the money. We just tell them, don't go above this. And then, oh dear, you went above this. Oh no.
Yeah.
But in Maryland, it's still all fee for service. It's just that they have to adjust their fees to have the budget work out right.
Yeah, and I think that is the way they have done it. I think they have, I don't know if they've switched to the population-based methodology, but they have been talking about moving to that methodology, and they have a total cost of care cap that they're now managing. So it has evolved in recent years, but that is how they've done it for a long time, is adjusting prices monthly to hit that budget. You're absolutely right.
Which sounds incredibly expensive administratively. I mean, it sounds very complex. I wasn't understanding how they were saving money with that. But I would be curious if you could explain a little bit more about what are they doing now? I wasn't quite catching that. If you could explain that again.
Yeah, no, I think they have been, and I don't know the extent to which, I don't have the details of their methodology, but they had been moving to a more lump sum payment instead of doing that monthly adjusting, because what it does is it swings prices high and low depending on how many patients come in for a particular service. So it's not a very rational process, and it's also unpredictable for patients and
So if the state of Maryland makes a lump sum payment to each hospital, where are they collecting that money from? Are they collecting it from a portion of the insurance rates, or are they taxing?
I think it's still the same multi-payer system. So they still so Maryland has had this system in place, or rate setting system in place, since the 80s consistently. So their Medicaid, Medicare, and commercial rates are all pretty similar. And they have kind of a different Medicare rate than many other hospitals or many other states.
So just for clarity, so a person, a beneficiary on commercial insurance in Maryland pays their premium to their insurance company, and their insurance company holds on to that money until there is a fee for service fee sent to them, and then they pay that bill.
Right. So I think once hospitals so that's why you have the prices fluctuating, or you had prices fluctuating, is so that they would ensure that budget cap, right?
Okay.
The lump sum payment, I'm not sure, it's whatever, the state would tell you a methodology and how often you would pay it, and for how, at the beneficiary level and which facility it would go to. So I don't know the mechanics of where they landed with their methodology, but I know that was what they were working on.
So if the state is telling the insurance companies pay this amount to this hospital, this amount to that hospital based on the number of beneficiaries you have, that seems like maybe a way that you could do global budgeting at the state level.
Yep.
But Vermont hasn't pursued that, is my understanding.
So I wouldn't say we haven't pursued it. We have so the feds had, let me see, when did that start? So just with the last administration, there was this ahead model. So that was kind of the next reform model. And it required hospital or states to adopt hospital global budgets. It had a certain number of hospitals that had to enter into that program. And then the state would kind of be responsible for developing a commercial program. There were a lot of flexibility in how you develop that. We were actively developing a global payment methodology. We even have a methodology drafted, and the state actually has an agreement signed with the federal government to continue negotiating and exploring the state's participation in this ahead model. Then the next administration came in and is relaunching the program, and it is very different than the program we initially started negotiating. So There's still a global budget component, but the state is still kind of evaluating what that means. And I think there's still a lot of uncertainties, even around program design. And so I wouldn't say that we haven't pursued it. I would just say that the options for doing that work are shifting. And I believe Maryland is even kind of reevaluating its options in the context of the shifting
The
federal.
changes, yeah.
Yeah.
So there, I don't, Marvin, have you spoken with the interns at all about the AHEAD program?
I would like to intervene right now. Sorry. I just want to say I want to go back to Adam Gaffney's lecture on global budgets for hospitals and start from there, because what we're talking about here is much more complex and unlikely to be effective, as Alena's already alluded to. What Adam was talking about when he said the best way is to pay hospital global budgets, that is a centralized, you could call it Stalinistic, very centralized system where the government has collected tax money, and that's the money that's going to run the healthcare system. And what Adam was suggesting was to divide it in two pots. One is for major changes like building a new hospital, the capital budget, and the bigger sum was the operating budget. And the government, in monthly aliquots, the government would just send each hospital their budget for that month, and that was it. So the government needed to get that right and give enough money to run the service, which you could extrapolate from the prior year from overall rates of health inflation, and try to get it right, and whatever. So it could end up the same way Alena just said, where it's not working out. But what's going on here is completely different. Imagine somebody who's a tourist in Maryland's capital, Annapolis. They have their car, they get into an auto wreck where they actually need an operation, and then they have a heart attack after the operation. You can imagine all the billing that goes on. The auto insurance is supposed to provide coverage for the auto wreck and the operation, and then the person may have private insurance. It could be a Medicare Advantage plan if they're over 65. It could be a regular insurance plan if they're under 65, or some other kind of insurance for whatever state they come from. So all this complexity of billing is still going on. But somehow, in a way I don't understand, the hospital, after billing for all that care to take care of that person, the state doesn't let them get the money. This is really complicated. And as Alena said, it's led to a displacement of care. Anytime that care could be done in a different facility, like some sort of outpatient clinic, it'll get displaced over there. And so the hospital still gets that revenue. So this is like a cat and mouse game, or I can't remember what this is called. Like the cost goes somewhere else, but doesn't really decrease the cost. So overall, Maryland's rate of inflation is not special compared to other states. Alena, is that fair?
Yeah.
And I do want to get back to Natalia.
Absolutely. No, I would agree with that.
All right. So Natalia, go ahead.
Yeah. I was just gonna ask what has been the most, I mean, it sounds like you guys are really in the middle of talks about what the best plan for Vermont is, but I'm curious if there's like a most popular option, something that seems the most promising, or something that you view as the most promising path forward in the context of Vermont.
That's a great question. I think depends how you define most promising. So I think, some of the other questions that Marvin shared will allude to the kind of looming threats on the horizon, and nothing feels particularly positive. So I think it's kind of how are we triaging and trying to figure out how we're going to adapt. And so I think if we think about the major challenges ahead of us, we have insurance affordability, and frankly, continued access to coverage. I really worry that in Vermont in particular, we're going to have some challenges with coverage in the near future. And then preserving essential services in particularly the most rural communities where they're financially unsustainable. And I think part of this is regulatory, perhaps part of this is as negotiating power, right? The smaller hospitals have not been able to negotiate the same prices that some of our other hospitals have been able to negotiate. And those negotiations happen outside of the regulatory process. And so when I think about what tools we have to try to move forward in a way that, leads to the least harm is kind of how I'm thinking about it. We have to rationalize prices, but we have to do it in such a way that will allow hospitals and the state to preserve essential services in the communities where they need to be preserved. And that has not been done in the US anywhere, but I do think we have conversations happening and a lot of good work and a lot of really committed people to try to solve those problems. So I think it's going to be a combination of thinking about how do we pay for care differently and shifting, which services we are paying higher prices for, really thinking about what we're trying to preserve, and then, bringing people to the table to really think about managing hospitals differently, right? Like we can't just be leaning on revenue generators. We need OB in our rural communities. We can't have, birthing ending up in the ED. We need to make sure we have a robust primary care system that is treating people before they get sick, and that we're not just sending everyone to the ED. And so those are the kinds of conversations we need to have. They're not regulatory conversations. They are, coalition building and stakeholder engagement and planning conversations. And that is happening outside of the board. And then I think the board will be looking for how it can leverage its regulatory duties and powers and processes to support that work. So I know it's a complicated answer, but.
Eve, do you have a question?
Yeah, thanks. Yeah, Alena, I'd just like to hear your perspective of what happened in 2011. And so Act 48 was passed that guaranteed all Vermont residents free healthcare. And I know it was never funded. There was a lot of different interests at play, but all of these innovative, how do we do healthcare within the current private insurance system programs were funded. And so what happened there? What was like the timeline and the interest at play, I guess, forcing away from the law that was already enacted into something else?
It's a very good question. And I was not here when that was passed. So a lot of what I know about that is through conversations I've had with other folks. So what I do understand is that Vermont was very, very close to having this happen. And some of the work that was being done to estimate how the costs would then be distributed became very challenging for people to build political will to sell, right? So I think if you think about what it means to shift from a multi-payer system to a single payer system, it means instead of, I flashed up that funds flow, you see all the different ways that money trickles to the healthcare system. It looks like a little bit here, a little bit there. You don't see the total cost. I think part of the challenge with healthcare is my employer's paying a piece, I'm paying a piece, I have an out-of-pocket piece, there's a piece coming out, so the total cost of healthcare to me is not very evident. And it's very hard to take that and then bundle it up and say, okay, now here's your your taxable piece. So now your taxes look very large, even though you may be getting efficiencies in aggregate. That's a very, very, very hard program to sell politically. And I think it just kind of fell apart at the end for that reason. And I don't know what the solution is to that problem, but that is what I've learned since my time here, at least one way of understanding that story. I think some people would say that it wasn't cost effective to implement. I don't think the data support that. I think if you look at the system level and the efficiencies gained, even with Vermont's small size, it could have been beneficial. So
on that same line, I had thought that we were going to be eliminating the commercial insurances, and that with the Green Mountain Care plan would be the payer, and we were going to try to figure out how to funnel the Medicare, Medicaid, et cetera, into that panel. But I heard one of our PNHP members who served on one of the advisory committees he was disgusted because what he was seeing was it was still a multi-payer plan, and that's why you couldn't get the efficiencies to actually save the money to pay for the extra care that would be provided to people who previously were uninsured or not accessing because they couldn't pay the deductible, et cetera. Can you clarify more about, like, was it still a multi-insurance plan and why?
Yeah, like I said, I wasn't in the weeds then, so I don't know how to answer that question appropriately, but I'm happy to try to find some materials if that would be helpful to.
That would be very helpful in terms of people who are still wondering and still pushing to why haven't we implemented Act 48, if we could understand that better.
Yeah.
Thank you.
Zach, you have a question?
This is
Can I add something quickly? Zach,
you
sorry,
got it.
Zach.
You got it.
My views on Act 48 are mine alone and don't reflect the view of the board. So I just want to say that. But go ahead, Zach.
I was looking at like the total expenses of like Dartmouth Hitchcock and the University of Vermont, and it seems like they have a similar like amount of like population that they serve in terms of volume. But UVM's expenses are like $2 billion, and Dartmouth Hitchcock's is $1 billion. So it's like a 2 times increase for seemingly serving a similar amount of patients. What are you expecting you could save in terms of spending at UVM? That seems like a huge disparity. Have you looked into like how like what a goal could be to decrease their expenses by?
Yeah, I think that's a great question. And I think there is this dynamic where Dartmouth has they do have kind of a higher, there's other things in there like case mix that are important and things like that. So volume alone isn't all of it, but I do think we have been thinking about what the opportunities are. I think in the immediate term, we have been thinking about UVM's role in driving the premiums for Blue Cross Blue Shield and kind of the solvency issues. And the dollar figure that was put on that was around $200 to $300 million. So we were looking, in order to reduce Blue Cross's rate from 25% down to 5%, we would have had to take out $200 to $300 million out of UVM Medical Center's budget. And what I mean take out, I mean they would have to take it out of their budget. I think so, but I think in the long run, if the goal was to create equity between Dartmouth and UVM, like that analysis hasn't been done, but we do have, there was a settlement process that occurred with UVM and kind of some of their budgetary debates last year. And so they ended up having an observer enter their organization that the state supported. There's a group of people looking at these opportunities and, where could these costs come from and where is this kind of disproportionate growth coming from? I think one of the things that they're looking at in particular is kind of, the value of the network and like, why do you have such huge administrative overhead and what are the functions of that? And so they're, we don't know yet. They're still doing a lot of their investigative work, but I think that's a great question. But I think some of it will come from kind of what is the work that you're doing and is it necessary and beneficial to the health and welfare of the Vermonters?
Alena, I have a real quick question. So you're saying now that it looks like for the amount of care they're providing, that this small tertiary care center, which is Vermont's largest hospital, UVM, that they're inefficient, that they're requiring a lot of money to do less work than a comparable hospital like Dartmouth. And Zach, noted that looking at their budgets. So I just want to say, the Green Mountain Care Board has been fighting UVM for at least 5 or 6 or 7 years. This is not new. The UVM's been wanting to spend more, and the Green Mountain Care Board and the state in general, people would like to control their insurance rates and not be paying so much. So there was a group of activists, very intelligent people, like many of them were retired government officials. Even the governor, I think, an ex-governor got involved, Republican governor, basically criticizing UVM and saying they're wasteful. And it seemed like the Green Mountain Care Board, it seemed like that really helped the Green Mountain Care Board to feel empowered. Because it may not be obvious to the interns, but it's questionable to me who has more power. Like, you think government's got all the power, but really you don't. The UVM is very powerful. And when the Green Mountain Care Board first started going after them, just this most recent round, say a year and a half ago, UVM kind of had a little temper tantrum, and they closed a whole bunch of services that the government did not want closed, like a primary care clinic, a really important psychiatric inpatient wing at the hospital near me. And it felt like a temper tantrum, like, we're losing money on these services. We don't care, you know, we're just going to do what we want if you start attacking us. And I felt like this citizens group of activists actually made a little difference there. What do you think?
I really appreciate this question, because I think it is fundamental that you have the right, you know, that the public is aware, and that you have advocates at the table saying, this isn't right. We need something different. Because who wants their government to have top-down authority on what you should be doing, right? Like, that is not going to get anyone anywhere. Imagine the board actually cut rates, but there was no awareness publicly of what was going on, or readiness, right? Hospitals go to their legislators hear from their constituents. Oh my God, they're cutting prices. They're trying to put in the hospital, setting the narrative. You're trying to put me out of business, and you don't care about patients. You're killing patients. This is always what hospitals say every year. You don't give me my price, you're killing patients. No, we don't give you your price. We give you your price, you're killing patients. They can't afford care. So, there is an absolutely necessary role of public engagement, of activists, of good data on the problems that will lead us to evidence-based solutions. So, government is not like this ultimate powerful thing that can fix everything. It's one actor in a larger system that needs to function together to actually achieve a public interest. So, Marvin, I really appreciate that question. I think it's really important.
Natalia?
Natalia, go ahead.
Yeah. I had sort of a follow-up question to that, and I was thinking about this earlier, but I think it fits here. You were talking about how with the budgets or the like ceilings that you'd given hospitals, they were going over them and then coming back to you and saying, okay, well, we went over the money, so we need like an increase. So and now you're talking about how like government isn't all powerful and they can't just like set whatever they want and people will comply. What are the consequences, like in the current system, what are the consequences to going over or like not complying? And is there a way to kind of get people to comply, I guess? I don't really know.
I mean, I think
Enforcement.
enforcement is the mechanism we currently have, and it's not very easy to retroactively pull money out of a system that's already been spent, right? And so I think that's why it's a real, like, it can be done. And I think the board members in this more recent iteration have been willing to stick their neck out to do more to pull prices down. So actually, I led the hospital budget process last year and recommended a 5% rate cut to UVM's budget, which has not been done in many years. And they approved that over a time span. But that's not enough. Like, we have really outgrown our skis here. And so I think while you have the right people, that can be done in the right context and the right momentum, we might also need to think about the tools that will help make those decisions easier. And I think that's why you've seen the shift, why global payments are perhaps a good strategy when thinking about, here's your budget, live within it. I think it is a little bit challenging for Vermont because we have access challenges already, and we don't want to see any further rationing of care. We need to recalibrate a little bit, but that's why folks have been talking about reference-based pricing or setting pricing caps to help kind of have something that's more enforceable than trying to do it on the back end once you've overspent your budget, because that is a lot more, politically and operationally challenging to implement.
Yeah, I'm going to have to intervene. I'm sorry, but I just want to say you're saying that for at least some of the insurers in the state, maybe Medicaid and Blue Cross, the ones you're more able to regulate, instead of allowing them separate negotiations between, say, Blue Cross and each hospital, this idea of setting a price, which in Vermont they're calling a reference-based price, would sort of link it, it would be some percentage a little bit above what Medicare pays. And that would apply to Medicaid and Blue Cross, whatever you're able to regulate. Is that right?
No, so I think, so we don't regulate, the board doesn't regulate Medicaid. There is already a separate mechanism for that through the Agency of Human Services, and they do rate setting. Some of that has been historically relative to Medicare, but it's not just a blanket percentage of Medicare. It really depends on the service. And I think they've actually had different payment reform programs beyond that have been more global budget like, global payment like. When we're talking about reference-based pricing, we're still in the early stages of thinking about what that looks like. It is not going to be, I think, because I'm going to be leading this with people, it is not going to be, nor will I propose a blanket across the board relative price. I think we need to think about something a little more nuanced that allows us to reallocate prices across our services and across hospitals. And it doesn't need to be one size fits all. We can think about a methodology that would reflect kind of the policy goals that I've been talking about, right? Like preserving access to essential services, making sure that we have sufficient funding in the areas that we, more rural areas that we need, that may be more vulnerable. And so reference-based pricing, I think, is a concept that allows us to set a cap or a floor at the service level. It doesn't need to be like 300% or 100% of Medicare, whatever it is. It's not, it can be more nuanced than that. I hope that helps.
Well, I'm pretty sure I don't understand, but
well, I hope you.
I guess
hope you
you
can get
want to.
there, so I'm happy to try again if that's. So if we think
I guess it's trying to get a little more. Go ahead.
No. It'd be good to understand what's not clear, and then I can.
Well, I thought you were talking about getting to one price for all the payers, or as many as you could regulate.
So we would get to one price at the service level for all the commercial payers in the market. So the way the statute is set up is to leverage the Green Mountain Care Board's rate setting authority, which is the price a hospital shall charge shall not exceed. I think we could also establish a floor for, like you must at least collect this amount for OB, for example. So it's an opportunity to say, we don't want you to go over this price, but you're still negotiating with your insurer, and we don't want you to go under this price for a different service. So we're trying to evolve the parameters of that program. We are just, like I said, kicking this off in the early stages, but it's really about setting parameters around what could be negotiated between hospitals and insurers.
Okay. Any questions from the interns or E or anyone else at this point? Because I think we should at least. Yeah, go ahead, Mackenzie. I do want to talk about rural stuff in a minute. But Mackenzie, go right ahead.
Sorry, real quick. For the parameters, would the parameters apply to all the hospitals, or would it be different for like a tertiary care, like a advanced center like UVM versus like a smaller rural hospital as far as like OB goes?
Yeah, no, it's a great question. So we're thinking through that right now. So we will kind of have, I think what we're kind of in the very early stages. So everything I'm saying is hypothetical. But I think we would want to anticipate different designation and the different work that's happening in the hospital when setting these prices. Yeah, or price caps. Yeah.
Yeah. E, go ahead.
Yeah, another follow-up question to that. I get that this is a incentive to, preserve these essential services that don't traditionally pay well, that hospitals would be like otherwise incentivized to cut. Does this plan reduce costs in any way? Because my understanding is that the main cost reduction would be to reduce the amount of administrative work, but there's still all of this negotiation going on within these caps that are different for different hospitals. So would that in fact increase administrative costs?
So that's a great question. It doesn't directly address administrative costs, so that is a challenge. If to the extent that it can specify a single methodology, it could simplify the billing practices on the hospital side so that they're billing all insurers the same way, regardless of whether you're, one commercial insurer or the other. Your first question about reducing costs, I think the idea would be that you would need to monitor kind of where you're reducing. Like, so, we know that UVM's outpatient centers, some of those services are upwards of 600% of Medicare. If we, take some of those down, say even to 300% of Medicare, it leaves room to increase prices in other areas that haven't received the benefit of their negotiating power, primary care, OB, et cetera, mental health. And so I think some of this is about how you implement these price adjustments. It won't be just to set it and forget it. Like, we're going to need to think about phasing in and how we do this over time.
Okay, so I just want to say a point of clarification. So nobody said this, but what you're alluding to is that some services are very profitable. And Vermont is similar to almost every other urban area I've been to, that if you listen to medical advertising from like hospital systems, they're always saying, do your knee replacement and your carpal tunnel surgery with us. And they'll say how great their elective orthopedics is, because the revenue they get from that is very high compared to the cost it takes to provide the service. Whereas primary care and mental health and obstetrics, they're all money losers. The cost of providing the service is higher than the expected revenue. So you could try to rectify these mismatches, and it sounds like that's what reference-based pricing might allow you to do. You could say to them, you may as well stop advertising elective orthopedics, because whatever you do, we're going to take that money before you get it, and we're going to give it to the obstetrical people and to the primary care people. Is that kind of what's happening?
I think that is the goal. That reallocation is part of the policy goal of implementing this program in Vermont because of kind of where we are with our prices and our service challenges. So I would agree, yeah.
Alena, I want to turn a little bit to rural. Okay, I guess we got some questions. I do want to get into the rural issue before we adjourn. So Zach, did you have a question?
I just want to say thank you. It sounds like this has been a very exhaustive process, and I've always been interested in different ways that you can like make health systems, instead of meeting like revenue goals, meet the goals of the community. And it seems like you're being very thorough, and I'm very interested. I've been interested in RVU reform and how that could potentially shift our like landscape on the federal level and like promoting primary care away from specialties. So I guess it kind of sounds like you're trying to do that on a state level with like reallocation of funds from the more profitable specialties to what people would typically consider like specialties that promote the health of the community. So I guess I'll have to keep an eye on Vermont moving forward.
Yeah, a lot of pressure. We hope we do right by many. So thank you.
Betty, go ahead. You're muted, I think.
So is it like right now you hear mostly people talk about, oh, 120% of Medicare, or they talk about percentages. But would a strategy be to say, okay, for OB we're going to pay this much, and it may be 300 or 400 what Medicare does, and for orthopedics we're going to do 80% up? I mean, could you like do a different case by case of the different services?
Absolutely. Yeah, that's what we're exploring,
Okay.
is how we would do that. What is the math equation that would help us figure out what those rates should be, right? And what are the variables that we want to consider in setting those rates? Yeah.
Thank you. Thank you.
All right.
I hadn't.
Vermont, anyone have a question? Anyone else? So it may surprise some people when you think about places like Montana or Wyoming that Vermont is actually the most rural state in the country, because in Montana and Wyoming, almost all the people live in their cities. So Vermont's population is distributed much more evenly throughout the state. Our metro area around Burlington only has about at most a third of the population and maybe less. So the rest of those people are scattered about, and there are 12, more or less, let's say 10 really rural hospitals that are pretty small, mostly having trouble, budgetary trouble. Because because the metro areas has the highest percentage of people with actual commercial insurance that pays more, and the rural areas are left with older people and poorer people who didn't go to school to educate themselves for a job that would tend to be more urban. So we're left with people with kind of not great health coverage as things go in the U.S. healthcare system. So rural hospitals across the country are in trouble, and this is equally true in Vermont. So I guess, Alena, do you know if anyone's is one problem with Vermont's healthcare system that not just that UVM may be overspending in the metro area, but that rural hospitals are just gonna die? I mean, you can't keep them going. I actually asked when they were threatening to close the hospital I worked in, which was in Chapter 11 bankruptcy for 18 months. I asked the Green Mountain Care Board, I was talking to one of its members, and they said, no, we don't keep the hospitals open. We just control, we're trying to control costs everywhere. So you can't really keep those services open. On the other hand, can you talk about that? You hired a consultant group, I think called Hammery or something like that, and they made fairly austere recommendations to close many things, several of the hospitals. And I'm just wondering, I'm creating a fairly hopeless or pessimistic at best picture of the future for rural hospitals, and I'm wondering how you and how the Green Mountain Care Board view that as an issue. Do they just all consolidate? And what's the problem? Is it is it the fact that they can't bill as high because there's not well-insured people, or is it economies of scale that these little hospitals lack? Like, what's the problem, and how might you solve it?
Yeah, I think that, and it's a really important and really hard question. So I don't think you're going to get the cost savings by consolidating all the small hospitals that you want, right? Like UVM is, serves, was it 70% of is the in-state revenue or something like that. So, I think part of the challenge with small hospitals is that and where this work started when I came to the board in 2019, was the Springfield bankruptcy. We don't have funds at the state to bail out hospitals. There are no funds. Like, we are barely paying for schools. The tax rates are very high. Healthcare insurance rates very high. We talked about that. There's no extra money. So what do you do if you can't subsidize small hospitals? You have to rethink how you're organizing care. So part of this work is, how do we preserve access to essential services in our rural communities? And that might mean you have to collaborate. I think also in that report is about how do we collaborate? How do we build centers of excellence? We don't want to end up with just two hospitals on either side of the state, UVM and Dartmouth. We know that we need care in our communities. So how do we make sure that whatever we're left with is intentional and not just what happens so we can keep the doors open? As you heard us talk about earlier, there are real incentives to prioritize some service lines over others that may not make sense for what Vermonters need. So that is kind of where this Oliver Wyman report, Bruce Hammery was a
Consultant.
consultant, and he used to lead division of Geisinger, so he helped with a lot of their kind of rural consolidations and rethinking about how they deliver care. And so he brought some of that expertise to Vermont to help us think about what could we be doing differently. So that report was really a menu of options given kind of the trajectories at the time. That report was based on very conservative data that are almost too aspirational. So I would even say that the financial situation coming forth for our rural hospitals is even more dire than what he had forecasted in that report, given what we know about the big bill that was recently passed and some of the other risks to our system. And so I think continuing to operate the way we've always operated will no longer be an option. And the question is, what do we do? And how do we triage and make sure that Vermonters are not left with healthcare deserts? And that is really, I think you're right, this is a crisis. And we're going to look different. And the question is, how are we going to look different? And how will we be able to pay for it with the resources that we have?
So they wanted to close some hospitals, 4 of them, right?
No,
and that
I
may
think
be what needs to happen.
I think that's what Bruce recommended. I don't know I don't know that exactly what's in the report is what's going to happen. The board is not going to close hospitals. The Agency of Human Services, which is a branch of the administration, and they work for the governor, is currently working with hospitals and communities to figure out, what could you do? Like what, given this report and given other data we have and given what we are kind of experiencing, where can you collaborate and build economies of scale, reduce costs, where to become more sustainable, and where can you kind of fill gaps of care, right? Like part of this report is what's not being provided in this community because they've already had to make hard choices, and can we bring some of that back as a result of rethinking how we work together?
All right.
So
I mean, Betty, do
I
you
had
wanna say something?
concerns about the consultant. Well, I had concerns when I saw his report and it had all these recommendations for what to do instead of what we are doing. What we are doing is unsustainable, but what he wrote also looked impossible. So like, how do you go from, he was recommending things that would require a transportation infrastructure that we don't have, and there was no estimate of what the cost would be to create that. And he was recommending stopping services, including obstetrical services in some areas. Like, what's the cost of like women dying if they can't get to care fast enough, right? So I was really discouraged with his report. I thought it had a lot of lacking, but then I looked up Oliver Wyman, and a large part of their work is doing consulting for private equity, which suddenly made me go, oh my God, he's trying to recommend that we close hospitals so that real estate people can buy the properties, or that they can suck stuff out before that. I was really dismayed. So I see you shaking your head. I'd like an explanation. Thank you.
Well, no, I just don't think it has anything to do with private equity, but that's my bias in having worked with Bruce. But I think it's a starting place. I think those are Bruce's recommendations, given his experience and his expertise. It doesn't mean that's what's right for Vermont, and it's why we're taking that report, Agency of Human Services, Vermont collectively, and kind of trying to think about what makes sense and, what are the quality implications of shutting OB? Like, I think there's a whole nother layer of work that is happening right now, and that may need to happen yet to really understand what we should be doing. This is voluntary work. The state is not telling hospitals what they can and can't do. We are trying to understand where the gaps in care are, and what's possible, and facilitating a conversation. So I wouldn't take Bruce's report as kind of any indication of what the future state will look like. I think it's just a place to start thinking about where could we reimagine how care is being delivered in context of this looming crisis, right? Ongoing.
Thank you so much. I just want to explain for the interns who have no idea what we're talking about right now, I suspect. So a few years ago, there was concern about, following Springfield Hospital filing for bankruptcy, there was concern about the long-term viability of our small rural hospitals. And eventually a bill, Act 167, was passed that required getting a consultant to look over our healthcare system and make recommendations. And so that was Act 167. And out of that, Oliver Wyman is a consulting firm that we contracted with, and they provided Dr. Hammery to give this report. He ran around the whole state, first interviewing what they call stakeholders and asking for public comment, and then he wrote a report, and then he went around the state showing that report for your local area, and getting input again. And then the final, it's called a report, but it's really like 132 or something slideshow. It's not actually a report. It doesn't have the depth of explanation written into the report for somebody who wasn't at the presentation to catch it all. But that's what we're talking about right now.
Okay, so we only have less than 5 minutes left. So there's this gorilla in the room. So far in this discussion, we've been talking about, we're on the level of like a million, few million dollars, like UVM's over budget by some limited number of $1 million. But there's this gorilla in Washington, D.C., known as the Big Beautiful Bill, that's not taking away a couple $1 million here and there. You're talking about tens of $1 millions for a size of the state of Vermont, and for larger states, proportional amount of money that is drastically cutting health spending to a degree that we've never discussed here, or exactly the same in other states. So I'm just wondering, what did you guys do, Alena, when suddenly they're really saying they're going to take tens of millions of dollars away from our budget? What do you do?
It's a very good question. The state is still evaluating kind of the impact of this bill. I say the state because a lot of what's in this bill is going to happen through Medicaid, which is, as I mentioned earlier, part of the Agency of Human Services under the administration. So the board doesn't regulate Medicaid. What has happened, I think, historically that we've been talking about a little bit is, well, actually, I don't even know if we talked about this explicitly. Medicare has fixed prices, Medicaid has fixed prices, and now that will reduce. And then you've seen this ballooning commercial, which is kind of subsuming the rest of the costs of the system. So, that's what we're really worried about. If we already have our commercial system that's totally tapped out to maintain this infrastructure, like there's nowhere else to go. So once you start taking out Medicaid, that means that services are going to change, right? Or hospitals are going to close. And that is really concerning. And I don't know that we know how the state or what the state can do to deal with that. I think part of what's in that bill, I can speak in general terms about, but again, is there's a lot of work to do to understand the specific implications. It's about enrollment, so it's going to be there's a lot of red tape and a lot harder to enroll in Medicaid, which means that you'll have lower levels of coverage and lower overall revenue going to hospitals for those patients, higher number of uninsured patients. And then there's changes to the provider tax, which is a way that the state pulls revenue out of hospitals and then kind of gets more money from the feds, or gets this match, and then delivers it back to the hospitals to support high Medicaid populations, or where there's more vulnerability. That's changing, and I don't know what the options are for the state, but people will have to figure out what the parameters are and how you can kind of make the most of it. So I think there's a lot of work to do there, and will require coordination across government and hospitals and providers to think about how we survive in this new context. So I don't have a great answer, but it's challenging.
Yeah, it may not be a great answer. Betty, do you want to make one final comment before we close?
Well, I guess, not a comment, but a question, but regarding how the Big Beautiful Bill impacts Vermont versus other states. So we have a Medicaid system, I believe that our state runs it and that the federal government pays a certain percentage. We states decide how much they add to it. So we would have to add more if they reduce their rates. But we're going to do we have a plan? Do we have a plan to increase our administrative costs so that we can help people stay on, like help them with that whole enrollment process so that we can still get reimbursed?
I think, yeah, I don't know what plans are already in place. I think they're still in the stage of evaluating the bill and monitoring what the guidance will be that's coming out of there and how it will affect us. So I think that's a great question for the Agency of Human Services. And they will be the ones that will be leading that work. Yeah.
Thank you.
Yeah. All right. Well, Alena, difficult topic, but thank you so much for taking this on. And I think one of the things I think this highlights is the limitations and challenges that state level reform faces in trying to contend with high costs in a complex multi-payer system. And, you know, I feel like you guys have, you know, giving it your best, and it's just, you're facing a tough challenge. So thank you. I appreciate your educating the next generation of doctors here. Thank you so much.
Yeah, thank you for having me, and happy to answer any follow-up questions you might have. This was fun, so appreciate it.
Thank you so much.
Thank
Yeah.
you.
Take
Thank
care.
Nice to
you.
meet you.
Bye.